Nandita, we have Halima. Those are the most important contestants here.
Right. So let's get started. Give me a second. I was going to show the cases, but today I'm also on service and I just saw something 10 minutes ago and I thought it's a good time to show that. I'll show that first before we jump into our cases. Okay, you have to let me share my screen. It says host disabled.
Yeah, let me. Okay, now you would be able to.
Okay. Share. Okay. Okay, so seeing my screen?
It's, yeah.
Yeah, okay. So one of the participants, can you tell me what you see? We discussed about this, but I got a good example today. So this is a lymph node. And we performed flow cytometry, and this is a B cell tube.
I do not know, but this kappa and lambda, which is just on that line, does not look fine to me.
It does not look, sorry, your voice got interrupted. It does not look what?
It's that rocket shape, like that we were discussing last time. That I mean, it's neither in the kappa nor in the lambda. It's just
exactly.
That was abnormal. That's not like it needs regating, something like that.
So this is debris. That's what this means. So if you look at it, you will see this in. If you, I think you can see my mouse. You see this in the same location, almost the same shape. The location may be a little bit here and there, but you see the same diagonal shape in all the plots, right? And then this is another tube. Again, in the other tube, it's the same diagonal shape in all the plots. It's here and there a little bit, but and then this is a T cell tube. So this is how we identify debris. If we see the same shape without being particularly positive for anything in all the plots. This is what we were talking the other day. So then, yeah.
So basically, what it means is like it's not going like any particular direction, right? It's not either going to kappa, lambda, or CD4, CD8. Whichever gate you put, it will show you the same stuff, right?
Exactly. So it just means that it is debris. So debris will have non-specific binding with the antigens and the fluorochromes, and they will have weird fluorescence. So they'll still pick up fluorescence, but you will not see that being specifically positive or committing to anything. You will see it in this diagonal shape in all the plots. And so then this is the viability testing on this one. If you see majority of these are the CD45 positive cells, and majority of them have 7-AAD positivity, which means it's
debris. It's not like these are nuclear debris bound to 7-AAD.
Yeah, exactly. So these are not viable cells. The only viable cells are this one, and those are not those are not identifiable with so much debris in the background. Probably some T cells, which are seen in the green population here. Like if you pay close attention, you can see some green color cells in the CD3, which are both 4 and we have both 4 and 8 positive cells. But majority of the cells are debris, and you see how their site scatter is also like all over. So just wanted to show you an example of this process. So
what did the morphology show on this one?
I don't know. So we got the flow. They just the lymph node was harvested today, so they submitted in the morning. We got the flow today. Morphology will come out later, maybe tomorrow.
Okay.
Yeah, I'll update you what it shows. I'm not sure if I'll see it. If Search Path finds something, they will sign it out.
Yeah.
Like some solid tumor, they'll sign it out. Let's see. All right, so now I'll go back to our cases.
Your desktop looks much more organized.
Oh, that's my second screen. That's why I'm sharing only my second screen, because my first screen is like full of, and also I'm signing out today, so patient information and stuff. I'm just so scared. Okay. All right, so who's going to volunteer for this case? This is first one. This is the B one.
I can do that.
Okay.
Yeah, so this one showed Let me know if my moderate is same as yours. I think it is CD20 moderate positive, CD19 moderate positive, and sorry, I move back. And it is kappa restricted. CD38 dim to moderate, CD5 positive, 23 positive, and 20 positive. And to me negative for CD10,
Right.
34, 71, and FMC7, they are all negative.
Okay.
So it is a kappa restricted CD5 positive B cell neoplasm. Based on the cell count, it could be an MBL or a CLL.
Okay. All right. So this is a lymph node.
Okay,
So,
then SLL, CLL.
Yeah, CLL, SLL. So if you see, one clue is if you see in the 45 versus side scatter, you don't see any grants or anything else. You only see the lymphocytes. I mean, like you said, it is possible in a peripheral blood with very high lymphocytosis, advanced CLL, you will probably just see just the lymphocytes, but at least there should be some grants.
Okay.
But it's okay. Even peripheral blood in advanced cases can look like this. You're right. And you are right that 20 is moderate. And first thing to look in a B cell tube is if the kappa and lambda are equal or if they are restricted. So here we don't see any lambda. All the B cells are kappa restricted. We identify the B cells by 20 positivity, and we see that the population, it's almost touching on the gate. So it's kind of moderate. Normal 20 would be like here nicely, around here, a little bit up. And one other thing is, if you see the kappa expression, it's not very bright kappa, it's a dim kappa, and that's something CLL does. The surface light chain expression is not very bright. In fact, there are cases of CLL where you will not see any surface light chain expression. So don't get, scared about it. That's normal. CLL does that. And other thing is this is negative for 10. And FMC7 is negative because FMC7 and bright CD20 always go together. So CLL usually has negative FMC7. And this is 19 positive. It is nicely 5 positive. These are your T cells here. And one other thing that you can nicely see in this CD45 versus side scatter is your T cells. This is the lymphocyte gate. And the left side is usually the B cells and the right side is usually the T cells. So they have the brightest CD45. You can see that here somewhat. You see the blue here, those are the T cells that are on the right side, and the left side is mostly occupied by the B cells. So these are CD5 positive T cells and these are the B cells. And you'll see that the B cells, the kappa restricted cells are mostly 23 positive and they're nicely 200 positive. So this is like a typical CLL phenotype. One more thing you have to remember is there is an entity in CLL that has trisomy 12. So that would have a little bit different phenotype. They can sometimes not have 23, and they might have brighter 20 also. And their phenotype will be a little different. But as long as you find out in flow that this is a kappa restricted monoclonal population, and if you are saying CD5 positive, that is sometimes enough if you're not able, if you do not have a classic phenotype. Okay, so now I also want to ask you a couple of things. Let's say in the kappa versus lambda plot, you see the population here, like where the two things merge on the top, not at the bottom. Not here, but here on the top. And it's not debris. Let's say it's nicely 20 positive. Everything else is nicely positive, but you see that population is here, in between kappa and lambda at the top. What do you think that means? Anybody?
Halima, you can rather than typing, just start talking.
Sorry about that. Wouldn't it be polyclonal?
So it would be like there is no good separation. It's just kind of sticking. So that would mean like they have to wash it more, and they do something called long incubation for that. And if it is here not showing positivity for either kappa or lambda, that could be because the chain that it is, the epitope that is being expressed is not in your cocktail. So then they add something called polyvalence that will have more epitopes or targets. So then that can sometimes help and it will show a kappa or lambda. You understand what I'm saying?
Yeah, got it.
So how do you differentiate that it is not expressing surface kappa lambda versus it is not having the epitopes then?
So we use the polyvalence to make sure. So if it is not expressing kappa lambda and if it is having a CLL phenotype or a lymphoblastic phenotype, we don't worry about it.
Okay.
We just go ahead and call it that. But if it is not having anything that is like CLL or a BALL, but it is not expressing kappa lambda, then we try the polyvalence.
Oh, okay. Good.
Yeah.
One more thing. I'm not used to using the CD200 before.
Okay.
What exactly do you do with it? I mean, I'm not.
CD200 has a utility only in Mantle and CLL. CD200 is positive in almost all low-grade lymphomas except Mantle. So that's where it helps between CLL and Mantle. When it is positive in a CD5 positive CD5 positive light chain restricted population, then we favor CLL.
And also, I think it is positive in very strongly positive in hairy cell leukemia, right?
200.
Yes.
I think it is positive in all the low-grade B-cell lymphomas. Hairy cell, I have to see. I think it.
Yeah.
I've seen it positive, but I don't know if it is very strong.
I mean, it is not a specific hairy cell marker. No one talks about
Yeah,
it in
no,
hairy
no.
cell.
Yeah,
No, it's
yeah, but
not.
that's the thing. Mantle is negative. That's what helps.
Yeah, that's where we use it. I mean, the CD200 we used to have only in the CLL tube, and that's it. Like we used to have a separate CLL tube, and we would
Yeah.
add the CLL when we would suspect CLL. So that's it.
Yes. Okay.
One last thing, sorry. You just told about in the very beginning plot of CD20 about the moderate intensity that you said it's touching the line. What does that mean? I didn't get that part. In the plots above. Yeah, here.
So it's like it's kind of touching this line, right? And you can even see a subset of this population crossing this line in the negative side. You see the line, the gate is at 10 power 3. So normal lymph nodes usually have do not touch the line. You see the line here? They don't touch.
Okay, now I get it. Okay.
Yeah.
I used to go by these numbers, like, if it's
10 power
between 10
3.
raised to power 2 to 3, it's low. 3 to 4 is moderate, and 4 and above is bright. That's how I used to do. This is okay, but I get your point now. It's touching the line and going trickling down.
Yeah,
So it's kind of dim to moderate kind of
yeah,
thing. Okay.
exactly. All right. So any other questions with this one? We can move on.
I
to
have
the
a
next.
question.
Yeah.
I have a question. So I always used to think, I mean, I think there was international group, some kind of discussion going on maybe this, I'm not sure what they were discussing. They were like, I want to know how these lines are made. Like, the middle lines, like some of them are at 10 to power 3, some of them are little less than 10 to power 3. Some of them are little more than 10 to power 3. Is there any specific way that these lines are made?
So I'm not exactly sure, but this is how the mean fluorescence intensity of these fluorochromes and antigen combination shows when we do, yeah. So it is derived from the mean fluorescence intensity.
So it is basically comes from the manufacturer.
No, when we do it in our lab, when we validate it in our lab, that's when we derive those lines. For example, if you see in the plasma cell tube, almost always we will run the IgG controls with it, right? Yeah. So when you see, hold on for a second. Let me stop sharing for a second and I'll share again. I will just pull up a plasma cell gate to show you, for example. That must be. Okay, so I have this case. Okay, I'm going to share my screen again. So if you see, this is an isotype tube that we always run with the plasma cell panel. And in this, we decide what is positive and what is negative, and then we adjust the gate along based on that. So for example, here is CD19. Sometimes we will drag this gate to this side or this side based on where the CD19 is positive in this one. Here is CD19. So CD19 is with which one? BV510. So we'll see where is BV510 here. So isotype BV510 is positive from here. So from 10 to the power 3, more to the right of 10 to the power 3. So that's where we will draw our gate here. So even if it is here, we will adjust it to that based on that and see what is positive. You understand what I'm saying?
Mm-hmm.
Yeah, so like this, when we validate our panel or when we do our QC every day, wherever your beads show positivity, that's where you decide.
Okay.
Yeah.
And to my understanding, I think it's more like a control population.
Right, exactly.
You do the patient specimens.
Right. Got you.
Could I also add a perspective?
Yes.
What I've seen that with each, when we, for example, from a lab tech perspective, whenever they do a sample, it's done in Navio software, and then it gets dragged into Kaluza software. And as soon as it does that, the lines are never in proper places. So for each case, these positive and negative lines have to be adjusted. And I think what they look for is, for example, for a plot for CD20. So for example, in here, the screen that I'm seeing, the fourth plot of kappa and 20, there's a small population at the bottom, and right at the bottom of it, right at the border of it, you can see the bigger population is starting, and that's where they placed their lines. So the one that separates between CD20 negative and CD20 positive. And same goes on the plot number 5. Again, the lines were in between where they saw what they thought a positive population of 20 is residing, and then the negative is residing just below it. So they do that for each single plot every single time.
So it's not standardized or anything?
No, it's not standardized. What I've seen, because the analysis happens in a different software on Navios. This and I'm talking about Beckman Coulter. I'm not sure about BD. And then when it's dragged in Kaluza, it's the way I've seen it analyzed is that you have to kind of adjust the lines. Or what can be done is that another case with a similarly suspected known positive is dragged in Kaluza, and then the unknown case is dragged on top of it. So the line kind of helps in figuring out where the positive population, negative population are. So that's what I found. I found one of the most challenging stuff, especially in bone marrows, which are really hypercellular, that it's so hard to divide between like where could be the, especially if the neoplasm cells are not that much, to find them behind all that and normal population.
So one other thing is, like, when sometimes in 10 colors these days, they don't make these lines anymore. So I have one that is coming, and I think my case 5 and 6 will have that kind of thing. There is no line there. So there they sometimes decide almost always decide positivity and negativity based on what a normal marker would be positive for. Like, for example, if they're saying cytoplasmic CD3, they will compare that with the normal T cells.
Right.
And if it is to that intensity, they will call it positive. Like
so
MPO,
that's what we used to do at MSK. That's why I haven't seen, like, when I came to this practice, I never asked this question to anyone, but I started seeing these lines. I was like, okay, I am not used to this. But they were very helpful. I mean, I found them really helpful. So I was like, okay, I'll just use it.
So we use these lines, and sometimes some of our antibody fluorochrome combinations have a lot of background, and we ignore these lines many a times, and then we say like, okay, even if this looks positive, it's not really positive, because for example our 56 will be hyperfluorescent always, and we used to ignore it unless it is like very, very on the extreme side. Like I think it's more like you get used to your antibodies and you know where they are positive for, and you don't stop seeing the lines after some time.
That's true. That's what, like, I'm not used to seeing the lines. I mean, they are helpful, but I mean, I rather would know what actually everything would sit and how it looks.
More relative, everything is
relative.
So you don't mention the percentage of positive cells then, like, because these lines will decide that percentage that I was used to mention in the report.
So so far the only percentage we have been asked for is CD20 expression on blast, because that decides therapy. Nothing else is we have been asked for percentage so far. It's either we report in terms of positive, negative, dim, or and then we use the word partial a lot. If something is, let's say for example here, like going from this side to this side like this, we'll say partial, and we don't say how much percentage is this, on this side or that side. We don't go into that.
Yeah, we don't go into that as well. And on everything, like anything that we say is how much percentage of that particular population is involved. So basically, if you have 77% of the lymphocytes are involved or something like that. And,
we say that too, right?
Yes, that's it. That's all that we, and then positive, negative, you can say. In Kaluza, I have seen that they had a practice over here that they used to tell every antigen, they used to tell this percentage, that percentage, and I tried to remove that from the practice, and now me and another person, we are not doing it because it's not useful at all.
Yeah, so while I was at Hopkins, we never gave percentage for anything except like the blast percentage. We gave the blast percentage, or like what percent of cells are monotypic or monoclonal, or what percent of T cells are LGLs, or what percent of T cells show loss of 26 in a cutaneous T cell lymphoma. That kind of numbers. We never gave individual numbers for antigen expression. Except
we never gave for in MSK as well, and in fact we would I mean, we would just mention all the antigens that we did, and like in here I have seen that there is a long list that you have to put each and every antigen percentage, which is kind of, I feel like it's not needed, and it's kind of, I should not say this, but bullshit. So I stopped doing this. I asked them to stop doing that. So yeah,
even some people, they make a table.
Yeah, that's what they make here.
Yeah, even in that table, Hopkins said partial heterogeneous.
Right. They don't call
bright, like that. They didn't give the percentage even in that one.
Right.
But I know that some people say if more than 20% of cells are positive, you call it positive. But we never got into that. Right. But it's also based on your practice, whatever your clinicians are used to seeing. So
in fact, our clinicians, one of like the attending that I convinced that he should also not do it. He in fact said that he was called in few cases based on those percentages that they were misinterpreting, and they were not understanding. For example, like if you have a CD5 and sometimes you say CD5 based on T cell and you're not sure when you are saying it about B cell, and it becomes confusing. And then at that moment of time, the clinician is kind of, oh, what's going on in here? Why is this there? And he gets confused, and it's kind of better to just avoid it, in my opinion.
Anybody else has anything else to add?
20% cells being positive in order to call positive, I think that's a standard rule.
Yeah, I heard that too, but it's just that we are not using it in.
Right, exactly.
We are not saying it as positive in both there and here. Right now I'm at VCU. We never called anything positive just by 20%. We called it partial. We never implemented that rule.
If it's at the margin.
Yeah. I mean, if it is at the margin, you can clearly say 20% of that population is positive. Even at that time, they did not say it is positive. They still said partial.
And at our institute, they used to basically compare it with the normal, and whatever with the normal will be. Like I didn't went through this session with you guys, but the ways that they used to call bright, dim, normal, and things like that, negative. So all of these they used to decide. They specifically have their definitions as how they are going to decide it, and some of them are based on how. So basically, how a particular antigen will be expressed in a cell that usually expresses it. For example, if you have a antigen that T cell expresses, and B cell is expressing that antigen brighter than the T cell that's the normal for T cell, so that it will be called as bright. So I mean, it depends on a lot of things, and that's how they were defining things, but they never used any 20% cutoff ever.
So I was told that, it gives a misconception sometimes when we use follow-ups. Like, for example, if a patient is going from one institute to other institute with the report, not with the flow plots. And if you say something is positive, if that because it is more than 20%, but actually it is partial, there is some possibility to imagine that it is homogeneously positive in that population rather than being partial. So they avoided that term for that reason, to to convey the.
It sort of goes with the fish rule. I mean, I've asked the same question there, where like if you have just one abnormal signal, they don't call it positive. They should, I mean, it differs for every test, and it's like, for example, if for one particular gene there should be more than 5 positive signals in order to call it. So something like that. I mean, I always used to ask, why do you need 5? Isn't 1 enough? So something like that here. I mean, the 20% should be there in order to call it positive. Otherwise, we are not confident enough to call it even partially positive. That's the point. And we, of course, have to also correlate
online. Like I said, I have 4 of them. So I could give you,
There's a
if you
background noise.
want, let me know. I can give you a couple others in between.
Yes, there is a background.
Yeah, I removed that.
Okay.
Cool. I like the discussions here.
It's good
Yeah,
to know.
this was good.
Familiar with these lines, though. I mean, that's been the, although if it's old rule, whatever, I think it's still good to know how these lines work, because when we go to a rural setting, we don't know what's available for us. So
also, I would just throw out there, the lines are there and they can be helpful, but it's all pattern. Like, don't let lines make you think something that's not real ever.
Right. Okay, so this is case 2. Any volunteers for case 2?
I can't see. Okay. Oh, is it the?
Can you see or no?
Have you opened it? Is this the case too?
Yeah.
Okay.
Isn't that the one that we were already doing?
Yeah,
Looks
I think
like that.
that's the one that we were already discussing.
Is it?
No, it's not.
no,
Yeah, okay, it's a close related. Yeah, who's gonna yeah,
I can.
Sure.
Hello.
Go ahead.
Yeah, so for the case 2 on this first page, what we are seeing is like we have gated a particular lymphocyte population that has been designated blue. It's positive for CD20 in the first one and negative for CD10. There's a small subset that is positive. It is also negative for CD34. The population is kappa restricted, as we can see on the second paragraph, with cap CD20 against kappa and CD20 against lambda. So it clearly shows that it's a kappa restricted population for now. It's negative for CD103 and it's positive for CD38. If I go down on this one, the same classes again, we are looking at it, and now we can see that this lymphoid population, as we discussed previously, if it's showing more CD45, so that's where we are looking at the T cells. So now we are concerned more of that maroon red. That's a B cell population that's positive for CD5 and negative for CD20 and negative for CDFNC7 as well as CD200. Based on what I see right now, it's a good candidate for a mantle cell lymphoma.
How will you report it, Akash?
I would call it a how should I say? Can I just not call it like mantle cell and rather like just call it like a B cell, a low grade B cell neoplasm? It's not low grade. I cannot say it unless I have Ki67. So
What will
maybe
be
a
your
B
top
cell,
line?
aberrant B cell population.
So you can say this is monotypic. It's kappa restricted. Clearly,
Yeah,
you
okay,
don't
yeah.
have to use the word aberrant. Aberrant, we usually use it for T cell. When it is B cells, we say if it is monoclonal or not. So this one, some people don't like the word monoclonal in flow. They say it's monotypic. Yes, that is correct. This is only monotypic. Clonal is from PCR. So it is a kappa restricted population and it is CD5 positive. We don't call mantle cell just by flow. We need cyclin D1 for that.
Yes.
Right. So that is the diagnostic definition of the diagnosis. So we only call CD5 positive monoclonal kappa restricted B cell population.
That's
This
what
is,
we would call to.
yeah. This
Yeah.
would be our top line for this one.
Okay, cool.
Yeah. One more thing I missed mentioning in when we discussed CLL. Always when we report CLL, we give the intensity of positivity for CD38 because that has a prognostic significance.
Mm-hmm.
So we do mention that. Yeah, somebody was about to ask a question, I think.
Yeah, always. So, in the second case, FMC7 was negative. Is it like that's how you see it normally, like in mantle cell? If you
No,
were to
usually
say-
it is positive, and in this case, it is negative.
I think she has an example of positive too.
Yeah, I have. Actually, even the 20 is not that bright in this case. We usually have it even more brighter. So I have another case for that. Another example.
Yeah, this one you cannot really say. And plus, there is a little bit partial FMC7, but that's really not something that is conclusive of anything.
Right,
I would not commit to anything on this one. I would know that this is CD5 positive, could be CLL, could be mantle cell, but I would just restrict it to saying CD5 positive monoclonal B cell population.
Yeah,
exactly. Right.
It's also positive for CD38.
Yeah, it is positive for CD38. It's okay. It can be positive for CD38.
Does CD38 have any significance in mantle cell lymphoma?
No, it doesn't.
Okay.
No. So one other thing I wanted to mention is in pediatric population, it is common to see some CD5 positive cells. Don't panic if you see that. Make sure they are polyclonal, and if they are polyclonal, it's normal. You can leave it at that. And also in the peripheral blood, you will see normal peripheral blood. You will see some CD23 and 200 positive cells. Again, they are polyclonal. So those are all normal. And maybe later sometime I'll pull up a normal peripheral blood and show you how the B cells will look like in normal blood. Okay, so any other questions? Okay, then we'll move to the next one.
I just had one question. So when we say like when we do not have much of a specimen or the viability is low and we cannot like put it into different tubes to run at a time, so sometimes they call us and ask us like, we have limited sample, what would you do? So is what you just showed on case 2, is this a part of the limited B cell panel, or like is the limited B cell panel does have some lesser antigens to work with?
Oh no, actually I just took the pages of the B cell panel because that is relevant for our discussion. But in a regular lymph node in our lab, we run both the B cells, T cells, and we have some plasma cell markers in there too, like surface markers. So in fact, this is 2 tube. So the LP1 is 1 tube. This LP4 is dragged from another tube, and LP2 is another tube. So we have 4 tubes for this: T cell, B cell, and there is one with some plasma cell markers, hairy cell markers, and things like that. So no, we have more than that.
So she took the pain to take it out from her cases, de-identify them, and then put them here. She really takes like she does really hard work for that.
Okay.
And to my knowledge,
Like later, Sorry, yeah, tell me.
And to my knowledge, if there is a suspicion for CLL, it's important to do a T cell panel because at least 10 to 15% of the cases have coexisting AITL. So it's important to do a T cell panel along with CLL.
I don't know if it is 10 to 15%.
That is new to me too.
Yeah.
Never seen that.
I was surprised too because I mean, we didn't do this, but this was mentioned at the neoplastic HemePath tutorial, the Cornell one. So that's where I too heard the same.
I mean, I've heard that AITL can happen in CLL, but I don't know about 10 to 15% seems to be very high.
Yeah, I mean, if it is 10 to 15%, I should have seen at least one by now.
Yeah, that's the reason why they say it's important to do a TCL with B.
Yeah, right. CLL.
There's a suspicion.
Yeah, that's right.
Okay.
You guys don't type in the chat. Start talking. Okay, go ahead. Sorry to interrupt.
Anything else? Or shall we move on to the next one? This is nice. Today is nice. A lot of people are talking.
I like that. That's what this is for.
Yeah.
Yeah. And I knew that when we have cases, that's what it will be much more fun than anything.
Yeah. Okay. Third one. Who's gonna do this?
I can do this.
Yeah, sure.
Okay. So in the first one, side scatter and CD45, we seem to have like increased lymphoid population with brighter CD45. Those cells in the second plot, they have bright CD20 and are negative for CD10. Again, in the next one, they are bright CD20 and negative for 34. Then they're negative for kappa. They seem positive for lambda, so lambda restricted. Again, in the next one, they're basically lambda restricted. 10 negative, 71 negative, 10 and 34 negative. Then they are CD5 positive, 19 positive, 23 negative, 19 positive. Then FMC7 positive as compared to the other one, which was FMC7 negative. Then 200 negative and 19 positive, 23 negative, then 19 positive, kappa negative, lambda positive. So basically like a monoclonal population of 19 positive, 20 positive, lambda restricted, 5 positive, FMC7 positive with bright CD20. So we'll call it as like CD5 positive lymphoma. This is like more suiting the picture of Mantle, though, like as you discussed earlier, we won't call it Mantle as such, but it's typical like 5 positive, FMC7 negative and bright CD20.
Yeah, okay, sounds good.
I have a question here. So we used to usually call things as bright, intermediate, dim. How does other practices do? Like, do you call them as positive, negative? How do you do that?
So we call it positive and negative. Bright only if it is like bright. We don't usually use bright for everything positive. Right. We call it bright only if it is higher than brighter than what we usually see.
Right.
Okay. Right. And if it is a CD5 positive neoplasm, we mention 20 if it is bright.
Yeah, that's true.
Just to give a clue that it doesn't look like a CLL 20. Just to put that indirectly.
Those established cases and the ones, I mean, that's the one on which we try to comment if it's dim, moderate, or strong.
Yeah.
We do the same. We only mention dim or bright for kappa, lambda, CD20, and only in the appropriate scenario. So
right.
Otherwise, just positive and negative and leave it at that. Yeah.
Got you. Yeah.
I have one question on this one with the bright CD20 and light chain very bright. I know CD5 doesn't go with it, but do you have concern with hairy cell on these ones? I know CD5 is usually negative in hairy cell, but would you do a panel for that, or you won't even go there because it is CD5 positive?
So one more thing is like there are some monocytes here. Hairy cells will have a monocytopenia. I mean, I'm just throwing it there because I'll forget to mention it later. But otherwise, your question is valid. Hairy cells are negative for CD5, so we won't usually do it. But in our regular tube, we have 103. But in my previous place, we did not do it unless we suspect when everything is negative and it is a monoclonal population. Then we added a hairy cell tube.
Okay. I was just concerned with the brightness of 20 and like lambda was like quite bright.
Yes, that is something that would prompt
okay.
us to do it, but because of the CD5, we would not have done
it. Yeah, I get that. Yes.
Yeah. Okay. Yes, we can go to the next one. Who's gonna do this one?
If nobody's doing, I can do it again. I mean,
sure.
I don't want to take the turns again and again. So, okay. So there is a population of CD20 moderate positive, CD10 moderate to bright positive, B cells. I actually have written it down and I'm going by that. Let me go by the plots. So it is CD20 positive, 10 positive, negative for 34, negative for kappa, positive for lambda, population of B cells, and yeah, I think I have covered all. Negative for 71. And negative for 34, I already said. 10 positive population is negative for 34. And we're not being there. Okay, and it is positive for 19 and 38. And negative for 5, negative for 200, negative, partially positive for FMC7. And
yeah, pretty much that's it.
Yeah, so I was more on the follicular lymphoma on this, and I think it's a germinal center, so that's why we kind of see a spectrum of things over here because we are other cells in that. So that's what I was thinking.
Okay, yeah, this one is follicular lymphoma, and you will see, you do see that the side scatter is not increased, and it is of a smaller size cells from this one. It is a follicular lymphoma, but when we signed out, we just signed it out as B-cell lymphoma of follicular center origin. Yeah, CD10 positive B-cell lymphoma. The other term, that some people sign it out that way, some people sign it out as B-cell lymphoma of follicle center origin. Either way.
We used to sign out as CD10 positive monoclonal B-cell population. And then sometimes, like as you were coming to the forward scatter and the side scatter, they help because the CD10 positive other lymphomas would be Burkitt's and DLBCL. I think we were discussing in the earlier session, and those will have higher forward scatter, side scatter. So that would be helpful, and that would be mentioned in the report.
Okay. Okay, so
do we have background noises?
On and off, we do get them.
Yeah, because everyone is talking, right? So now everyone's background is coming.
Anything else?
Is it this one from John Hopkins?
Yeah, this is from Hopkins, yes.
Yeah, I thought so, yeah.
So here they don't use any lines or anything. And this also has all the cells in it, so we can compare the intensity also with other ones.
Yeah, that's how we used to have.
Okay, so who's gonna do this one? Oh, are we done with the discussion on the other one? Any questions? Sorry, I assumed there will be no questions. Any questions or discussions, comments? Okay, let's do this. Who's gonna do this one?
I'm not used to this plot actually, so it took me a long while to understand like which population am I targeting at.
Exactly, you know, that is what takes time when you start initially, and if your tech doesn't clean up the background.
Oh my
God.
And
then there is a problem with this, like there is a 38. One of the plot is 38 positive, another is 38 negative. That makes such a difference in the my thinking.
That gives you the clue actually, Shweta, you know. But I was telling the experience at MSK. Oh my God, they are so busy plots, and they notice like the 3 or 4 dots, and they start enlarging those 3 or 4 dots, and then I start losing my mind. Sorry, go ahead. Yeah, so Raji, go ahead.
Yeah, so who's gonna do this one?
My guess was on plasma cell neoplasm on it based on the plots, but my 38 on one of the graphs, I'm not sure where I would put that.
Okay, so which one is your suspected population? Which color?
Which one was it? I think the next plot was more, I was looking, can you go to the next one? Sorry, I did it a while ago, so I'm kind of, that blue one, I think that is, earlier I was looking at the green one, and then, yeah, I think I'm looking at the green one. Yeah.
Okay, so maybe this one you find it easy. So let's start with this one and we'll go back to that one. Okay, so this is a 38 versus side scatter. We usually use 38 versus side scatter to isolate the plasma cells. And also there is another clue here that it says cytolambda, cytokappa. So this is a cytoplasmic tube, right? We are not talking about the surface. So this is a cytoplasmic tube. It does get a little messy, and this is a cleaner version. I didn't give you the messy one to make your life easy. So we have different populations here, but anyway, what all these are bright for CD38, they're all plasma cells. Okay, so do you want to take it from here, or you want me to go over?
Do this plot, the previous one. I mean, I'm okay with the rest of those except for 38 in the previous plot. I do not know where that will go. So here we see 38 positive cells. They are also positive for CD138, and there is CD19 is there on a dimmer side, and then they are more of I would say lambda restricted to me, maybe. Maybe. I'm not sure on this one. It's just like I'm not used to looking at.
Okay, so I'm gonna jump and use a sequence here. Okay, so these are all plasma cells. So normal plasma cells will have CD19, and neoplastic plasma cells will lose CD19. So that's what they did here. They did 19 on subgate. They took this population and they saw how the 19 expression is, and they saw here that there are a mixture of cells, green and red, and there are cells that do not have 19, so they just colored that population as blue, right? When you see the mixture of green and red, that is actually, if you see here in the cytoplasmic kappa and lambda, the green is here, the red is actually here. You can see that the blue is kind of hiding it a little bit, but the red is here. So basically the green is lambda and the red is kappa. So those are your normal polyclonal plasma cells. And this is the 19 negative abnormal plasma cells. And these are like, if you draw imaginary line like here in between, you will see that these blue population are on the side of kappa. Like they will fall, like let's imagine there is a diagonal line here, and this will be on this side, on the kappa side, and these are lambda, these are kappa. So the abnormal cells are kappa restricted, and they do not have 117 expression. They are all negative for 117. And again, this is again showing that how the normal cells are positive for 19. This is negative for 19, and you see that they are negative for 56. And they are, this is interesting because normal plasma cells will show CD27 expression. So they are on the positive side, and you'll see a little bit of normal cells that are negative. So always in 56, in 200, in 117, you might see like 3-4 cells going up there. That's okay, unless like the majority of the cells are on the positive side, they are not worrisome. Same way, majority of the cells are positive for 27, the normal cells, just 3-4 are sitting in the negative side. That's okay, but majority of your abnormal cells are negative for 27. So that is reassuring that it is abnormal. And our abnormal plasma cells usually lose 45, but here they still have good 45. So that is something unusual, but okay, it's still fine. They have other aberrant markers to help us. And abnormal plasma cells express 200, like in this case, they have 200, and your normal plasma cells do not have 200. So far, we see the aberrancy is that they have lost 19, and they have lost 27, and they have expression of 200. Okay, so we have a population of kappa restricted aberrant plasma cells. Okay, that is one side. Now we have the other side of the picture. We have a population that is positive, dim positive for CD19, and it is actually kappa restricted. It is here. If you see the aqua, follow the aqua. That is negative for CD19. And this is a surface tube, so you won't see the plasma cells here. They're there, but they are this dark brown cells here with the brightest CD30. These are the plasma cells, and okay. But majority of the cells that we are trying to see here are the B cells. And your B cells show a little bit dim to negative CD19, and they don't have CD10. They have partial CD200. They have CD20. So this is how you can say that they are not just plasma cells, because you have 20 also.
So this is LPL then?
Right, this is an LPL, but abnormal plasma cells can still express a little bit of 20. We need to be careful. So you have, that's why we have the 20 versus 38 plot here. The plasma cells are here, and we don't see anything here, right? That is positive both for 38 and 20. So these are B cells. So you have a clone of a B cell, and we have a clone of a plasma cell. So just to tell you what the other population is, so you have this yellow color showing very high side scatter, and that is also positive for CD10. What do you think that would be?
I want to say that.
Huh?
Granulocytes?
Yes, myeloids, granulocytes. And there is this, again, green and red population that is positive for CD19, and it has some lambda and some kappa.
Normal plasma cells?
Okay, they also have 20.
B cells?
Yes, normal B cells. So they are positive for 19 and 20. They are a mixture of kappa and lambda. So, and what else can we see from, but I think we don't have markers to, okay, this one, this orange population that is positive for CD5, negative for CD19.
T cells?
Negative for CD20. Sorry?
T cells?
T cells, yes, T cells, exactly. So yeah, so you can tell what they are. The green is actually, this fluorescent green is actually monocytes, but we don't have any markers to say that, so forget that. But anyway, so you can tell, if you try to analyze one by one, you can tell what they are. Here, basically, the clue is it is CD20 positive, and it is light chain restricted. So you have a population of B cells and plasma cells. So it is an LPL. Obviously, you cannot say it is an LPL without MYD88. You can say kappa restricted B cells with plasmacytic differentiation. Or I mean, that's in your final report, but when we report this flow, we write two lines. One line of this percentage of kappa restricted B cells, and then the second line of this percentage of kappa restricted plasma cells.
Right,
that's how we report.
Yeah. Actually, I'm gonna show you the reports that we used to have at MSK. Like if we get the time, maybe today, as to how the reporting would be done on these cases. Like we used to have templates for these cases, and I'll show you the templates. But anyways, I was saying that this case we should definitely have in our book. Yes, I love this.
Let me see what I had, the other one. Oh, okay, so maybe we can do this case tomorrow.
Okay.
I'm going to stop sharing, and I'm going to find something. In the meantime, Akansha might talk something. I want to find something.
I can try to find my my flow that I was going to show. Let's see. It should be somewhere.
I want to reshare after I find a case.
Yeah.
Okay.
So desktop, I think I have it in somewhere here. Yes. SOPs. Yes, this one. Okay, so we used to have these kind of, so because there was like a lot of flow at MSK, and I mean, we didn't used to get to see all of them because many of them were interpreted by the text, and we would just, like maybe sometimes pay attention when it is interesting. But we used to get like hundreds and hundreds of flow per day, and this was very important for them to report. There were so many texts, and they would have all of these quick text that they would report, and then everything was all all very organized in there. So for example, in CLL, that's if there is a first time bone marrow tissue or fluid, if there is a CLL, then they would say abnormal B cell population identified, and then they will say what it is. So the flow cytometry identified abnormal B cell population with CLL, SLL like immunophenotype, having abnormal expression of 5, 20 dim, 22 dim, 23, 200 bright, and whatever surface light chain. Normal expression of 19 and 45 without FMC 7, 28, and or 10 expression. So this will be, and then the abnormal B cell comprises of that many % of white cells. So this is how we used to report that. If there is a peripheral blood, and if they want to, if they know that there is a CLL absolute count of CLL more than 0.5, then they would mention that this line, that expression is diagnostic of CLL SLL. So that's what they would add in there. If there is a follow-up case of CLL SLL, and if there is a follow-up, then they would add the line that consistent with the previously diagnosed CLL. So that's like obviously like obvious reasons that we are going to add those things, but they had everything written down in here, and they would just quick test and done with it. Again, in the peripheral blood, if it is a follow-up, they would just say the same things like consistent with the previously diagnosed CLL, SLL, and the abnormal B cell comprises of whatever. And then they would they could also insert 1,000 per microliter. I mean, I don't do that in my reports, but they would do that. CD5. So then comes to mantle cell. First time mantle cell lymphoma, they would mention abnormal B cell again. So the top line would be most of the times the same. And they would then say abnormal expression of 5, dim CD19, surface light chain, bright, and then normal expression of CD20, 22, FMC7, 38, and so forth, without 10, 200, and 23. And then they would mention this comment. They would say, this immunophenotype is not entirely specific and does not allow full classification by flow cytometry. Correlation with IHC, cytogenetics for cyclin D1 is also recommended to rule out mantle cell. So though that they mentioned that there is FMC 7, there is no 23, there is no 200, so we know that it is mantle cell, but they would add this comment that correlation with cyclin D1 is recommended, and they would throw in there the mantle cell name, but they would say that this is needed for ruling out mantle cell. Follow-up of mantle cell, they would say that it is consistent with the previously diagnosed mantle cell along with the other things. For marginal zone, so that the top line could be CD5, CD10 negative B cell lymphoma, or maybe just abnormal B cell population identified. And then they would list the abnormalities. They would say the light chain restriction, and then they would say that without CD5, CD10. And then they would say how many percentage, and then they would say that it is not again entirely specific for the, does not allow for full classification for flow cytometry, and morphologic, cytogenetic, and molecular genetic studies will be required. Coming to follow-up of some marginal or mild lymphoma, which is CD5, CD10 negative. So again, they would say that abnormal B cell population identified, and they would have everything. And then in the last line, they would say the immunophenotype of abnormal B cell population is similar to the previously identified and is consistent with the previously diagnosed whatever. And the abnormal population is that much % of total white cells. Coming to CD10 positive lymphomas, for example, DLBCL and follicular. So DLBCL, they would again say abnormal B cell population identified, and then they would mention that it is an abnormal mature. So it's not a mature B cell population with abnormal whatever abnormalities they had, and then increased forward and light scatter. That's what I was saying, that they throw in there suggestive of larger size, and then whatever light chain restriction, and then expression of whatever markers with no 5 and 10. And or if there is a 10, then they would throw in 10 there, what if based on if it is a GCB type or not. And abnormal B cell represents whatever type. Morphologic correlation will be required to rule out large B cell lymphoma. So again, they would throw in there that hint, but again, they would not commit to it. Follicular lymphoma, so they had the CD10 dim and CD19 dim in there. Again, abnormal mature B cell population. And we know that it is mature, the CD20 is bright and everything. There's light chain restriction and all of that. And they would just say abnormal B cells. They would not throw in a follicular name in here. I mean, they if it is already identified follicular before, then they would say that it is consistent with prior follicular, but not the first time. Then LPL, Waldenstrom's LPM. So these, they would say abnormal B cell and plasma cell populations identified, and then they would mention the B cell and the plasma cell separately. So abnormal B cell with abnormal list of expression, and then normal list of expression without 5 or 10. So we know that LPL and marginal, they don't have 5 and 10. And then in addition, abnormal plasma cell is identified. So the plasma cell they would list again, and then they would mention whatever the abnormalities and normalities or whatever are in those plasma cells. So then given the similar light chain restriction, these populations likely represent manifestations of the same neoplasm. This is just a template. It's not necessary that it will be in all the cases. But the immunophenotype profiles do not allow for specific classification. And then the abnormal B cells is this much %, abnormal plasma cells is this much %, and clinical morphologic correlation. So that's that. I think this is a little helpful. I mean, I'll try to see if I can. I might put it in the flow course materials too. I mean, I think it is useful.
Okay, so I want to just show something briefly. If you guys still have time.
Yeah, sure. Please.
Okay. So can someone volunteer for this one? So this is a patient who had a history of follicular lymphoma, and this was a follow-up bone marrow they did for staging.
Did he receive rituximab then?
Yeah, 20 negative.
Okay. That's it?
No, there is another twist to it.
10 positive, and then it's kappa negative.
There's another twist to it.
19.
There's another twist to it.
I mean, it's surface antigen negative. It's kappa, immunoglobulin, like kappa lambda negative. That's something you have to think of.
Yes.
Why is that happening? 19 positive.
And where is it in this side scatter versus CD4? This is a real case. This was my case. The patient had a history of follicular lymphoma treated, and they did the bone marrow just for follow-up.
And I see some CD45 dim population. The blue population is CD45 dim, which is strange.
Do we have a plot of 10 versus 20 somewhere?
This is 10
Oh,
versus
we do
20.
have this one. No, okay, this one is there.
So here's the thing: the patient. The patient did not receive rituximab in the last 2 years.
I would want to see the other markers as well, the abnormal myeloids. And I mean, this is really, I should not actually, this will not be fair. Go ahead.
So what they did was they first did a bone marrow biopsy. They didn't find, what they did was the patient had a history of follicular lymphoma and now had some, fatigue and B symptoms. But in the last 2 years, he did not receive any rituximab. So they did a PET and they found one spot in the bone marrow that lit up. So they tried to do a bone marrow biopsy that did not help. So they went on and did a FNA biopsy of the bone marrow. So we didn't run everything in there because it was a FN core and we only got very minute tissue for flow. So we only did the B and T cell tube and there was nothing in the T cell tube, empty. This is all we got. And you can say that
I was thinking was hematogones, but it doesn't show the spectrum for it. Like, which
are they blasts?
Yeah.
Yeah, that's what they are.
Yeah.
So this patient actually had lymphoblastic transformation of a follicular lymphoma. And he had an additional MYC translocation and TDT was very brightly positive, but we did it in the immunostain. We did not do it in the flow because we ran out of tissue. But the clue is side scatter versus 45, it is sitting here and it does not have surface 20 despite the patient being not treated for rituximab for 2 years. That's what I first thought. But then the lack of surface light chains and presence here kind of made us feel like, no, this is not follicular lymphoma, this is something else. So
and why I was saying that I wanted to see other markers as well, because they can have some aberrancies and like some myeloid antigens they can acquire as well. So those aberrancies as well sometimes help. TDT may or may not help. 34 may or may not help. Not
It
all
might
people.
sometimes acquire 1333. That's an aberrant marker in
Right.
BALL, but
Right.
we never ran that tube because we just didn't have
because
tissue. Yeah, and we clinicians and we both thought that because it is a very localized PET positive lesion, because it was not in the entire marrow. The marrow was biopsied before and was negative. So it was very unusual for BALL to present so localized like that. So clinically, and even we thought it could be just relapse, but this one threw us off. So just wanted to show you guys.
I have seen such a local involvement of BALL. Like one of the BALLs that I have seen, there was a small, tiny population of blasts in the bone marrow, and everything else was very good. Like it was so focal. I was like, is this just a focal population of hematogones or what? I mean, I was so confused in that one, but that was really
If it is hematogones, you will also see an accompanying population of mature lymphocytes. That won't be there won't be paucity of lymphocytes here, and hematogones usually lie here in this area below the blast gate. And you will see it starting from here and going on and merging with the lymphocyte gate. It will be like a continuous population going like that.
And even in the other places like CD10, CD20 and others, they will be like a variable expression and a continuous kind of going from 20 to 10, but it will not be like this.
I have a question. In the on the next page, there is the blast cells are showing patch 200 positivity. Does
Yeah,
that signify
you can
anything?
See. No, blast can be positive for 200 normally also. Okay. BALL blast can be positive for 200. That's okay. And even AML blast can have some 200 expression. That's okay.
Okay. And then one more question from another case with 27. Like, what does 27, like, which cells can be positive for 27? Is it specific for anything or like?
It is only done in plasma cell neoplasms. 27, 81, 200, all of these are 117. All of these are aberrancies that you look for plasma cell neoplasm. So when you have abnormal plasma cell, that comes in the plasma cell tube.
Okay, so normal plasma cells will be 27 negative and abnormal will be positive.
No, normal would be positive.
Normal will be positive and abnormal will lose the expression.
Lose it, yes.
Okay. And also sometimes like we used to have 81 as well. So 81 is also helpful. Like they will lose 19, they will lose 27, they will lose 81, they will gain 117, they will gain 200. So all of those things are abnormal.
Okay, got it. Thank you.
56 is very important too.
Just wanted to show here, like this is where hematogones will sit, the black population here, and they'll be in a spectrum and they will join the lymphocytes here. And when you see the 10 versus 20, you will see that waterfall or knee shaped thing here.
I'm looking at this and I am thinking our book has bright future.
Yeah, okay guys, any other question? You know, this is why I prefer to do it in my office, because if I think about something, I can just pull it out.
Yeah, I agree with that. Yeah, that makes sense.
Right. Yeah. Okay.
This session was super interesting and informative.
I know.
Thank you so much.
Yeah, that's why like when we start cases, it always becomes interesting. Yeah. And I mean, this is still the B lymphoid. When we go to myeloid, you can scratch your heads.
Yeah. I don't know if that will be helpful. I mean, maybe we can only stick to doing cases rather than studying Brentwood or ACE the boards. I mean, in the original plan, I was thinking that maybe we can see what Brentwood has something else to say, like, you know, like some pointers that he can give as well. And ACE boards, maybe some highlights. But I think that the most of the time in such scenarios will be taken by the cases. Like today it was different because this one I had kept 2-hour session originally.
Yeah,
but then postponed. So let's see how it goes. I mean, B cells, I don't think we need to read a lot in B cells. I think we can skip that as well. I mean, depending on what you guys want to do, what you want to do.
If we are voting, I vote for cases.
Yeah, cases will always be there. I'm talking about, do you want to do additionally the book?
I think like we can do cases and then after like 2-3 sessions of cases, one day or like half day, if we can do like just quickly review some important points
from the book. Yeah.
Yeah.
Yeah. Yeah, okay. We can do that, or just give us reading material. Like when you come for cases, this is your pre-course review material. Do it and then come.
अरे कितने
Yeah,
लोग पढ़ते हैं यार?
yeah,
Do you have
that
time for that? You guys have time?
Exactly, कितने लोग पढ़ते हैं
Yeah,
यार?
वो
नहीं है time. I don't have time, man.
same.
I mean, I'm glad that people reviewed the cases before, so I was like, and
Yeah.
I made sure that I kind of remind them because I know that they would not even do that.
And then I think also going for like through the important points together like helps build
Yeah.
concepts better rather than just
Yeah,
going.
I vote for going for important points together. Like that really helped because then we all are on the same page, like
Yeah.
for the markers, and we are using the same graphs, like putting it in our head together.
I think especially like T cell and myeloid would be like T cell would be very difficult. Like I find T cell super difficult. Like B cell, I think still like it's okay. So
yeah, B is
probably-
more common and we've seen more, so we are more comfortable.
yeah.
Right.
So otherwise with T, I think it's, I mean, from what we've heard so far, it's probably a good idea to have some pre-course reading material and then brush through the important points of that particular topic before the session beginning or at the beginning of the session and then continue with the cases.
You mean that going through the, I mean, I found Brentwood book the best, so that's why I chose that. So maybe going through, so my plan was going through Brentwood after, so that we have already discussed and it is already interesting and we know, like it becomes very challenging or interesting when you have some challenging cases, and then going to the book and reading some important points that we feel have not been covered in the case. So, but you're proposing that we should have a book first and then cases. That's what you're saying?
Well, that's my preference, but anything is fine. However it works for everyone.
I mean, we are not in a rush. So it's rather be comprehensive, but not too elaborate. I would like to include some points of Brentwood in there because he does have some good points that we might or might not cover. I would take the vote of people. I would. I have like, even if we skip Brentwood, I'm fine. That's fine.
No, I think we should go with Brentwood definitely together. That's what I feel. And I before and after doesn't like can either way is fine, but we should go through like key points of Brentwood together.
Yeah, I think that would make it very complete.
Correct,
Yeah,
exactly.
That's what my plan
I
was.
concur too.
Yeah. Okay. Okay. So then in the next session, because it's already 5:13, people have to go home. So in the next session, we can briefly, I mean, I'll try to read the Brentwood myself, try to highlight it, and we can briefly go through any important points that have been missed. Sounds like a plan?
Yeah.
Yeah.
Thank you.
What are the pages from Brentwood, if you could mention in the group later,
They
that's
have
fine
chapter
too.
numbers. If you see the schedule, it shows the chapter numbers.
Oh, okay, sure. Yeah, sorry, this is my first day. I was busy with the move, so I will look into the material and everything today.
I'm glad
Sure.
you could join. That's great.
Yep.
Okay, yeah, so you have, if you see the flow course material, Priya, you will see the schedule in there as well.
Sure.
And so though we are not entirely following the date-wise schedule, but the sequence we are going to follow, and then chapters as well.
Sure.
So we can do that.
I'll
And in
look at
fact, if you get time, just read that. We can take turns in taking the important points, talking about the important points, and that way we won't even like waste time in reading what we already know, you know?
Yep. Sure, let's see. Okay,
All
thank
right.
you all.
Thank you. Thank you
Thank
very
you,
much.
guys.
Thank you. Bye-bye.
Thank
Raj,
you.
Thank you so much.
that was
Bye-bye.
very fantastic. You took time to do all of this, and you are still saying that you will take time eventually as well, which is fantastic, fantastic. I'm sorry that I don't have a way to natural language search these cases. And
No, that's okay. Finding cases is easier for me because we have a systematic way of.
Right. Yeah.
Yeah, it's easy to search and find. That's not a problem.
Yeah. Good.
But
Very good.
I feel very comfortable doing it in my office because it's so easy to do it here.
Yeah. Agree with that. Yeah. Let's stick to 4 to 5. That's good.
Okay. Yeah. Okay. All right.
All
Thank
right.
you.
Yes. Thank you.
Thank you.
Bye.
Bye-bye.